And we are live. We'll give folks just a couple seconds to get on. We'll get started at 3:30 on the dot. Okay. Just one more minute and we will get started. Hi there, and welcome to our event focused on providing vital opioid resources to our valued trades professionals and their employers. My name is Emma Shirey. I'm the Director of Outreach and Communication at the Maryland Center for Construction, Education, and Innovation. Our collaborative effort with the University of Maryland, Baltimore has yielded crucial insights into the opioid crisis within our community, and we're proud to provide actionable strategies for both individuals, bystanders, and their employers. Our distinguished speakers, Dr. Marianne Cloran and Dr. Jody Jacobson Fry, have dedicated their careers to understanding and addressing the complexities of opioid use and its impact on work disability. Through their pioneering initiatives such as Operation Prosper, they've been instrumental in developing practical tools and interventions to combat this pressing issue. Throughout our sessions, if you have any questions or comments, please feel free to place them in the comment section below, wherever you are. Our team will be moderating that chat and we'll address the most pertinent questions at the end of the webinar. Your active participation will contribute to the depth and richness of our discussion. So let us work together to foster a safe, healthier, and more resistant working environment for all. Thank you so much for being a part of this important conversation, and I will let you ladies take it away.
Great, thank you very much. So I'm Marianne Cloran, and I'm here with my colleague Jody Fry. Our objectives today are to describe some of the research findings related to opioid use disorder risk, particularly in the construction industry. Think about and share with you some of the reasons for this increased risk. Talk a little about your role in both caring for yourself, but also in maybe helping coworkers who may be at risk. Introduce you to some resources that are available to help individuals struggling with opioid use disorder, and hopefully prepare you to intervene when your help is needed to support or even save the life of a coworker. That's me when my hair was lighter or darker, not as gray. I'm an associate professor at the University of Maryland School of Medicine in the Division of Occupational and Environmental Medicine. For those of you that don't know, occupational medicine is a medical specialty that deals with work and health, the intersection between work and health. I think probably most people in construction have heard about occupational medicine. My own research interests relate to trying to prevent preventable work disability, because we know that working is good for people. And I've spent a lot of time working on opioid-related issues and how opioids can interfere with working. Dr. Fry is a professor, and she's also the Associate Dean for Research at the University of Maryland School of Social Work. And she's also works at the same intersection of work and health, and has done a lot of work on employee assistance programs, as well as behavioral health in the workplace, suicide prevention in the workplace, etc. Next slide. We have, over the years that we've been collaborating, received funding from a several different sources. And these are some of the projects that we've worked on and where the funding has come from. We'll speak a little bit more about the first two that you see here. And I just wanted to mention that we got started together with some grants from the University of Maryland, Baltimore, looking at what are the barriers to work participation for people with opioid use disorder. Next slide. So just think about the context of this. It's a really big issue, right? We all know that we've got this opioid epidemic that is a wicked problem. They use the term wicked problem in public health to talk about things that are multifactorial and really hard to solve. And so we started thinking about, well, what are the individual and workplace barriers that are keeping people, even people that are in recovery, from fully participating in the workplace? And that was kind of our first phase. And as a result of that, we recognize that peer coaches, people that have lived experience and are working with others, have a really important potential role here. And we're really happy to see that there's increasing attention to including peer coaches as part of the solution. And we'll touch on that a little bit here. And then we've been spending a lot of time in the last couple of years on something we call Workplace Prosper, and we'll define that later on. But that is trying to engage employers as partners in addressing the opioid epidemic. Next slide. So what is the research? Oh, this is you. Am I turning it over to you? Yes. Turning it over to Dr. Fry.
Thanks, Dr. Cloran. Really happy to be here today and to talk about this very important topic. So I'm going to open up with some of the research in terms of what are the risks in construction. And this is actually something in our forthcoming toolkit that you'll hear about, but we think it's important to start off and have you think about your own workplace. Is there an opioid problem where you work? And we can't see you, so we can't ask for a raise of hands, but really want you to kind of reflect on this. And probably a lot of you might be saying, no, we don't have a problem, or not sure, maybe. So let's think about what are some of the potential indicators that there could be a problem. And we just want you to reflect on some of these. Is there illicit drug use by employees at work? Is there illicit drug use by employees while not at work? Is there use of prescription opioids that are affecting work performance? Are there overdoses at work? This one probably maybe not as many of you have seen, but we know from our stakeholders and our research that these do often happen outside of work and affect work. Is naloxone or Narcan not readily available at your work? We'll talk a lot about this today. And are there workers' comp injuries that are being treated with opioids? Are employees in opioid recovery treated differently? And we'll get into stigma. Is there a lack of support for employees in recovery? And we'll have you start thinking about policies and programs. Is there a company culture that promotes alcohol or drug use? And are there employees with substance-related problems who are afraid to ask for help? And finally, is treatment for opioid use disorder not included in health benefits? If you answered yes to any of these, you're not alone. And what we're seeing is that construction is at very high risk for opioid use overdose. Why is that? 1 out of 3 construction workers have a musculoskeletal disorder. And then take that a step further, prescription opioids are used 3 times higher among construction workers with musculoskeletal disorders. And that increases risk significantly, as we're going to show in some of the research today. And in fact, some of our national statistics here from the CDC and the National Institute of Occupational Safety and Health find that overdose deaths in construction increased 9 times from 2011 to 2018. The Substance Abuse and Mental Health Services Administration, or SAMHSA, helps us to understand the context of broader substance use in the workplace. And in fact, the research there, and you can see some of the references. By the way, if anyone would like the slides, they will be sent out to you. following this webinar, and there's references and links in the notes so that you can get the direct data. But the majority of adults in the US with an alcohol or illicit drug use disorder are employed. And this is about 13.6 million workers, which is about 9% of employed adults. So it's a large population. And it also tells us that the workplace is a really important but yet untapped environment where we can make a difference through prevention, education, intervention, and recovery. So a lot of times when Dr. Clorin and I work with businesses, they want to know the bottom line. They often understand that some of these topics that we address in our daily life are important and a good thing to invest in for the health and well-being of employees, but they're also running a business. And so this is actually the National Safety Council developed a substance use cost calculator. Now, bear with me. I'm going to switch my slides because I want to show you a demonstration so you can think about what this is costing you. So I'm actually going to go into the substance use calculator, and let me reshare my screen for you. And you can go to nsc.org. And this is based on national data that's collected on substance use for industries. And we actually can look through different states to calculate an estimation of what substance use disorder is costing us. I'm going to start in retail. Okay, that's not the topic that we're doing today, but let's look at in the retail industry in Maryland, and we'll say 100 employees. We can calculate an automated report to get an estimation of what it's costing us. It's costing us $61,522 in a combination of lost time, job turnover, and healthcare costs. Further, you can delineate different ways that recovery is good for your business, in addition to saving lives. And it can also break down employees and dependents and family members who's affected and what type of substances folks might be using. And you might be thinking, well, why is she showing me retail? So let's keep that number in mind again, the 62,000. And let's compare it to construction in Maryland. Same size company, 100. Oops, that was Massachusetts. And that's Maine. Okay, I have slippery fingers today. Maryland, 100 employees. Let's run our report. Look at the costs. They're more than double, 131,000. Same size company, retail compared to construction, lost work time, job recovery training, and healthcare. We see this pattern over and over again, which is why I'm so honored to be here today to talk about solutions and what you can be doing to support coworkers in the construction industry. So we just wanted to show that as an example. You can go onto the site. It's free and available to anybody so that you can put in your actual numbers for your workplace. You can compare multiple states and compare different industries to get a breakdown. I'm going to go back to my slides here. And again, that resource is available at nsc.org. That is the substance use calculator. I know last year, the focus for the organization was on mental health and suicide prevention. They also have a mental health calculator. So important to take a look at some of those tools when you're talking with business leaders about why they should invest in prevention. So I wanted to present a couple other risk factors here before we go into solution. You can see some of the different states listed. Louisiana has a rate 4 times opioid overdose compared to other workers. Massachusetts has the highest rate and number of opioid-related deaths. Ohio has 7 times more likely folks to die of opioid overdose than other workers. And the National Safety Council, where we just pulled that data from, tells us that 1 in 5 construction workers has a substance use disorder. So the rates are very high, and a lot of the risks do overlap with mental health and suicide risk as well. And we included the rate for construction workers for suicide nationally is 45 per 100,000 people compared to 14.1, which is the national average. So some of our research has been focusing on Maryland specifically. We're going to share with you some of the data that's not yet published from the State Unintentional Drug and Overdose Reporting Surveillance System, or SUDORS. And what we found looking at the most recent publicly available data to us from 2018 is that, similar to other states, but not exactly the same as all, construction is at the highest risk for opioid overdose, followed by manufacturing and transportation. This was a little bit about who's in that sample in Maryland of over 2,000 people who have died by opioid-related overdose deaths. The majority are male, the majority are white, followed by Black employees, and 100% are in their working aged years. And again, this data is from 2018. And when we look at a comparison of industry trends for rates, you can see up here the construction and manufacturing and transportation rates, 21.25 per 10,000 people for construction. And there's a huge gap. As you can see, the second leading industry of manufacturing is 9.98 people per 10,000. So construction is really not only at highest risk, but they're also, as an industry, taking this head on, really investing resources in prevention. Why are they at higher risk? There's a lot of different reasons. These are a few that our research tells us. Again, looking at how opioid prescriptions are used, there's a higher risk that one will become a long-term opioid user and develop an opioid use disorder. So annually, 15% of workers are prescribed opioids, and that are prescribed opioids become long-term users. Long-term users then have a 10 times level risk of developing a disorder compared to those who prescribed fewer opioids. Construction workers also often have less access to paid sick leave. If you're not working, you're not getting paid. They often have interruptions and breaks in health insurance, and their treatment benefits might be limited, as we found a lot of folks do not have access to different types of treatment for opioid use disorder and their health benefits. There's also a lot of job stressors. The combination of high job demands, low control, and low social support are psychosocial stressors that kind of come with the territory of being a construction worker that contribute to risk. And oftentimes they're working in an industry or in a workplace that discourages help seeking. There's often a pull yourself up by the bootstraps mentality. And a lot of times people are treated punitively when they come forward seeking help for substance use. So we're also looking at some data from workers' comp. That was one of the risks that I presented on the slide where a lot of risks came up. And we're doing a secondary data analysis from the Chesapeake Employers Insurance Company. And this data includes different types of employers, occupations, diagnoses, and treatment codes. One of the things that we're interested in is, are there trends in industries and occupations about receiving inappropriate opioid prescriptions? And so first, our team has been working to define what is inappropriate. And this is when we see opioids prescribed for minor injuries, attention to contusions, sprains, and strains. And we saw from our research that this can lead to longer term use and development of opioid use disorder. So long-acting opioids prescribed at a first visit. So we have restricted the research here to just look at claims within the first 2 months, because as the claims get longer, it's a little more challenging to determine inappropriate prescribing. So what we're finding, first, a positive trend. Opioid prescribing has decreased over the years of 2008 to 2016. So that is a good finding. But unfortunately, we are still seeing that opioid prescription rates are higher for minor injuries, what we have defined as inappropriate, where they're not indicated for more severe injury conditions. And so this means that people working in the industries, and you'll see again, construction is at the top of the list, were more likely in Maryland to receive opioid prescriptions after we adjusted for those diagnostic groups for gender and for year. So what do we do about this? That's really what we're going to focus on here. So obviously, if we can, we want to prevent injuries. So looking at the environment, a focus on safety, but also having informed workers that have access to treatment, that can question and ask about prescribing practices and really think about the best ways to treat their injuries so they can return to work holistically and healthy. But there's other aspects that we also should be involved with in combating the risks. Some involve culture, and we're going to talk about how to reduce stigma about opioids and about substances and treatment, how to really take a good look at our policies of what's working and what we need to really rethink differently, and how do we train not only our workers, but also the managers. We want to make sure that we're providing appropriate support for folks that are seeking help. A lot of emphasis has been on peer support. People often want to talk to folks that have been through this themselves, that understand the stressors at work, and then also can be supportive long-term for recovery. We want to make sure folks have access to the right benefits with the best care, and that the community resources are set up to really help them to be successful in their recovery. And finally, we want to focus on harm reduction. And we're going to talk about naloxone today as something that you can do right away at your workplace as a way to start reducing the risk for overdose death. So I'm going to turn it back over to Dr. Cloran, who's going to talk about stigma.
All right. So stigma is something we hear a lot about. I think when you start thinking about stigma and the words that we use, you may recognize that you have some implicit biases. I know that I do. I think we all do. We all have ways of thinking that we may have been kind of brought up with. So what is stigma? The dictionary definition, from the Oxford English Dictionary, and I think this is an interesting definition, is a mark of disgrace. That's a strong word, associated with a particular circumstance, quality, or person. Next bullet. But when we're using it in this context, we're talking about discrimination against an identifiable group of people, or maybe a place or a nation. That's another way we can define stigma. With substance use disorder, stigma, the concept of stigma includes inaccurate thoughts and thoughts that are not grounded in reality, like that people with substance use disorder are dangerous or incapable of managing their treatment, or somehow responsible for their condition. Next slide. So I'm going to throw some examples out at you. So one is using drugs or alcohol as a choice. So if someone gets addicted, it's their fault. And I'm sure I know I've heard this. I imagine all of you have heard this. So is this fact or is this fiction? And this is fiction. Research shows over and over again that substance use disorders are medical conditions, and they're treatable medical conditions. So, some of us may believe that addiction only happens to certain types of people. Is this fact or is this fiction? And this again is fiction. Addiction can happen to anyone, no matter their race, their upbringing, their personality type, or other characteristics. Next slide. This is from kind of a medical article about trying to change the way we as physicians and nurses and social workers, the way we describe patients. Because our literature and our reports and our medical records are full of stigmatizing language. And so this came out as recommendations, but even though it's really for healthcare providers, I think that all of us can use most of this. And so instead of calling somebody a drunk, now some of the descriptive language is much longer. It takes longer to say some of this, but it's more accurate to say a person in recovery than to say a former addict. And it's rather than calling somebody an addict, recommendation is a person with a substance use disorder, because calling somebody an addict is stigmatizing. Next slide. And it's more that the person has a problem, it's not that the person is the problem themselves. Instead of referring to use as a habit, The recommendation is to say substance use disorder instead of abuse for illicit drugs. It's somebody who uses illicit drugs. For prescription medications, if they're using them inappropriately, not as they're prescribed, then it's misuse or use other than prescribed. Next slide. Clean and dirty have certain connotations, and so it's better to say testing negative or testing positive. Next slide. And one of the things that we've learned in our original research together, we worked with some, the next slide, we worked with some employers and had some focus groups with workforce development agencies and others that were working with people in recovery and trying to become employed. And one of the things that we learned from employers is that if you do invest your time, if you foster someone who's in early recovery, then those people tend to work really hard and end up being great employees in the long run. Does that mean that every time you hire somebody in recovery, it's going to be successful and without any bumps? No. There may be some bumps in the road. There are bumps in the road with people without substance use disorder as well. Next slide. We do know that employment during recovery is really important, that unemployment, not working, is associated with worse health, that people with opioid use disorder are, even though the majority of people with a substance use disorder are working, people with opioid use disorder are more likely to be unemployed than working. And people in treatment, even people in treatment with opioid use disorder, are also more likely to be unemployed than working. And unemployment increases the risk for overdose, while employment, stable employment, increases treatment adherence and successful recovery. So employment really helps people recover. Some of the ways to reduce stigma are training. And stories are important. Telling stories of the real people and what they've been through can be really useful in promoting hope and making people care about recovery, making people care about each other. Employers can also develop policies that emphasize supporting employees in recovery or supporting employees that need help. Some employers are putting into place peer support programs, and in the construction industry, there are also peer support programs that are based in the trade unions. So there are a couple different options there. This is still kind of new. It's not available everywhere, but there's a growing attention to that kind of program. And also, we need to think about treatment resources for employees, but also their families. Sometimes people are struggling at work because of something happening with a family member that relates to substance use disorder. Next slide. And I'm turning it back over to Dr. Fry for the next round.
Thank you, Dr. Cloran. That was great to look at some of the different ways that we can reduce stigma. And we also want to make sure that you have resources. So there's a lot of government-driven initiatives and other resources that are available to help employers to be partners in this work. So some of the work that is out there is based on New Hampshire models of recovery-friendly workplaces, and some of you may be familiar with that. And this is a website if you'd like to learn more. Also, the Department of Labor has some similar programs, but they have a different approach, a different name. They say recovery-ready workplaces. And the National Institute of Occupational Safety and Health talks about workplace-supported recovery. So there's a lot going on that involve employers as part of the overall strategies to reduce risk and to decrease stigma and to increase treatment and recovery. In Maryland, we are also doing quite a bit of work. This is a little bit of what Dr. Cloran mentioned with our own grants through Workplace Prosper. And we are working to develop a statewide toolkit, a resource for employers that employees also will have access to help them hire, engage, retain, and include employees who are in recovery. We're also working with the Opioid Operational Command Center here in Maryland on a project focused specifically on bringing naloxone training for construction workers. And the Maryland Department of Labor has been very busy working on recovery-friendly workplace policies and resources. So Dr. Cloran and I are part of the advisory council for a group that started July 2023, where the Department of Labor was awarded funds through Maryland Department of Health and Behavioral Health Administration to support pilot initiatives in 3 high-need areas in our state, including Western Maryland, the Susquehanna region, and St. Mary's County. So this is some pretty exciting cutting edge work that's happening at Maryland Department of Labor to think specifically about how employers, business owners, and others can participate in becoming more recovery friendly. And we're excited to see where these initiatives go this year for our state. So we've mentioned Workplace Prosper a little bit, so we're going to dive into that. This stands for Partnering to Reduce Opioid Stigma and Promote Employment and Recovery. And we really see the workplace as a central place for, again, where prevention and education and intervention and recovery can take place. So it's kind of a microcosm, including influences and aspects of government and research, working with employers and unions, and also paying attention to individuals and raising the voice of those with lived experience, as well as family members, and how coworkers can be supportive. So we've been doing a survey of employers in Maryland, and we'd love for you to think about your own workplace. This is a snapshot of what are some of the current policies and programs that Maryland employers are offering. And you can see referral to employee assistance and drug testing are some of the most commonly reported current policies and programs. I will say that a number of folks that responded to this survey thus far are in safety sensitive types of industries, and therefore they have more regulations for drug testing. You might be thinking, we don't have an EAP, we're a small business, or we're not actively doing drug testing unless it's after a post accident. So some of these might be more common about employee benefits, to treat opioids, having initiatives with workforce development programs to hire people in recovery from opioid use disorder. And so we're using this data to help us create a toolkit that really responds to what are the unique needs and desires of Maryland employers, construction included. And these are the 4 areas that we've been told are most important to hear about and to have examples in the toolkit throughout the state that we're working to finish. So stigma reducing education, family and community supports, naloxone in the workplace, and policy examples. Some examples of policy are, again, getting into the recovery-friendly alternatives and standards for drug-free workplace policies. What does it mean? How can they have flexibility? How can employers get involved? As well as including treatment for opioid use disorder and caring for family members with Family Medical Leave Act policies, for example. We found a number of our employers aren't sure if treatment for opioid use disorders are included in their benefits, including some of our benefit administrators. So how can we promote a culture of health and caring when we're not even sure what's included? And then being able to provide support for family members that may be caregivers or struggling themselves. And as you heard, workers bring that stress to work. We're also thinking about return to work plans that follow treatment. Again, how to support someone, whether it be through peer support, management training, having flexible options to receive medication to support recovery, and thinking about reasonable accommodations, again, to allow for opioid use treatment. Someone who's, taking methadone, for example, needs to be able to get their medication that's life-saving, that helps to really sustain recovery. And our workplace needs to think about accommodating a need, just like we would accommodate if someone needed to go for physical therapy for treatment of a break or a sprain. And this was mentioned earlier, just kind of thinking about what are those events that we have that are that are focused on alcohol, and what kind of trigger that could be in an environment for someone in recovery. Are we offering safe alternatives, and are we thinking about a culture of health that really gives other types of ways for a company to build rapport and establish morale and camaraderie without having alcohol. So some of the areas that we're covering in our toolkit are the consequences for active substance use. There's a zero tolerance policy. What does that mean? Does your organization use that approach? Or do they, really encourage people to come forward to seek help and to be in recovery? Language matters here in our policies as well. Did you catch someone with a drug testing, or did someone come forward and disclose, I'm struggling, I need some help, and is my employer going to have my back? Even thinking about last chance agreements, what does that mean? If we think about substance use is a medical disorder, should we treat it in a punitive way, or should we maybe have a crossroads conversation? Just really thinking about the culture of the workplace here. And most employers do monitoring for compliance. What if we thought about that in a way that actually supported recovery versus trying to catch someone? The history again of substance use is the need for treatment, being protected under the Americans with Disabilities Act, but active substance use is not covered under the ADA. Should it be? If we're saying we're equating this to a medical condition rather than an infraction and a problem, maybe we need to rethink some of our policies. Oops, I thought I had one more bullet point, but I don't. So I'm going to turn it back to Dr. Cloran to talk about naloxone in the workplace.
Great. All right. So naloxone. I came across somebody the other day that had never heard of it. I was really surprised about that because I feel like it gets a lot of press. Some of what we hear about naloxone is not true. One of the things that we've heard sometimes, I just gave you a hint what the answer is here. Is this fact or is this fiction? So some people think that naloxone is another drug that can be abused. However, that's totally fiction. It's got no potential for abuse. Naloxone blocks opioids at the opioid receptors, and it doesn't do anything if there's no opioids on board. Next slide. We've heard some people think that naloxone being around kind of prevents people from seeking treatment. Is this fact or is this fiction? Again, this is fiction. And for many people, the experience of surviving an overdose, pushes them to seek treatment. And it may not this time. Sometimes people do have overdoses multiple times. That does happen sometimes. But if you can reverse an overdose, that gives that person a chance to think about things and another day seek treatment, right? And it may not be today, but if they die, it's definitely not going to be today. Next slide. Naloxone enables addiction. Is that fact or is that fiction? Naloxone enables recovery, again, because it allows a person to live and perhaps seek treatment in the future. And there have been some. If you expect that you're going to save somebody's life with naloxone, and they're going to have a hallelujah moment and go right into treatment, that doesn't happen all that often. But without saving a person's life from an overdose, there's no opportunity for recovery. Next slide. This one's an interesting one. There's a belief that naloxone makes people violent. Is this true or is this false? People coming out of an overdose. And so there have been some rare kind of case reports of people getting combative after naloxone. It is actually really rare. And studies have looked at how people come out of an overdose with naloxone. And most commonly, there's some disorientation or confusion. There can be withdrawal symptoms. The person may not feel very happy about the situation when they receive naloxone, but the violence is extremely rare. Next slide. Administering naloxone to someone who doesn't need it can hurt them. What if you give it to someone and their problem has nothing to do with opioids? What if the person had a heart attack, or what if the person had a diabetes crisis and they passed out from that? Can we hurt them by giving them naloxone? And the answer is no. That's fiction as well. Again, naloxone acts at the opioid receptors to block the opioid. And if there's no opioids there, it doesn't do anything. It won't cause any harm. You can save a life with naloxone. Is that true? This one's true. It does prevent death by blocking the effect of opioids in the body. So, next slide. What's the place of naloxone at work? There are some different implementation options. One of them is via the Maryland Center for Harm Reduction, which will provide free training and also kits to everybody that they train via local overdose response programs that are staged all over the state. Now, depending on where you are, there may or may not be one of these programs really close to you. The more kind of rural you get, the less likely it is that there are going to be a lot of overdose response programs. But the county health departments will be able to help you in those situations. So this is basically available to everyone. And when you get the slides, if you click on that, you can look at your address and see what overdose response programs are near you. And it's just a matter of contacting them. They'll come and do training and provide the training and the kits. There's also a case to be made, go back, please. There's also a case to be made for staging naloxone in the workplace. So what the Maryland Center for Harm Reduction will do is they'll come and provide training, and everybody that gets the training gets a naloxone kit to take with them. And so that's a way to get all your employees trained, or a group of employees trained. But another approach, and you could do both, is staging it like with the automatic external defibrillators, like and so at a construction, well, I'm sorry, I'm babbling a little bit. For workplaces that have AEDs, the defibrillators, sometimes they'll stage naloxone nearby too, so that people that are trained to be first responders know where it is, and if somebody goes down, they can go and get it and potentially save a life. In construction sites, things work a little bit differently, and there may be different ways to stage it. Maybe I've heard in the porta potties. I've heard in toolkits maybe, or maybe in the safety manager's gear. So there are many kind of different approaches there. If you wanted to do that, we could provide advice about that. In this case, though, the naloxone would not be free. It wouldn't be delivered via the state. But it's becoming less expensive, and it's going over the counter soon, which is important. Next slide. NIOSH, the National Institute for Occupational Safety and Health, which is a branch of the Centers for Disease Control and Prevention, has provided guidance for workplace adoption of naloxone. And they've put together a workplace naloxone toolkit, which includes a sample policy template, resources for developing workplace champions and training of your employees. In the toolkit is all the information you could need about naloxone, a system for reporting its use, information about legal considerations. Some people worry about what's the legality of this, frequently asked questions, and naloxone mythbusters. Now, when we reviewed that as part of our Workplace Prosper program, we found it was a really good tool, but we thought that it needed even a little bit more customizing and to make it really ready to, shovel ready, to make it easy for workplaces to adopt it. And so this is one of the things that we're putting in the Maryland toolkit to make it easier for employers to be able to put this into place. Next slide. So these are just some food. This is just some food for thought. Have you thought, and feel free to put something in the chat if you want, but have you or has your workplace, if you're not the employer, has your employer talked at all about making naloxone available at work? Is it available already? That would be awesome. And what would be the value of that? And what might be some barriers to putting that into place? Next slide. We are working with the Maryland Opioid Operational Command Center in a grant that we got started in July, and it goes through June of next year, to try to increase getting naloxone into the hands of construction workers, because as we've hopefully made clear throughout this, construction workers are at very high risk, much higher risk than other kinds of workers. And so we think it's really important that every construction worker gets naloxone. The objectives of our project are to try to engage Maryland construction industry leaders to help them understand the value of naloxone training using kind of something called academic detailing. Next slide. And to connect the leaders with naloxone training. Next. Help coordinate the training and distribution. So you can look up the ORPs yourself and make the plans yourself, but we also have a project in place to help you with that. Because we're finding that the logistics are a little bit tricky sometimes. It may not be that easy to figure out how to get this training for your workers. So our project involves helping make that happen. And then also as part of this project, we're documenting what are the challenges and what has made it easier, what's working, what doesn't work. Next slide. We have an advisory board for this project, and we're using the advisory board to help us understand the best ways to engage construction leaders, to review outreach materials, to talk about the logistics of available training options, and also to discuss things like naloxone availability. Once it's over the counter in Maryland, will construction leaders want to just pay for it themselves and take care of it themselves, or will they be counting on the state to supply it? Next slide. And this is just listing the advisory board members. We've had quite a lot of wonderful participation by trade associations, by the Center for Construction Research and Training, by trade councils. The labor unions are already wonderful partners in this. Safe Project, if you're not aware of it, is another great partner. Next slide. This is just a clip from something that we've used to engage construction leaders. We bring this to trade shows and meetings, but it goes through some of the Maryland statistics. You know, the fact that there were over 2,200 opioid overdose deaths in Maryland, and that this increased about 3 times in a decade. Now that 2,200 is not all construction workers, but across the state, the industry sector most impacted was construction. And individuals working in construction accounted for about 22% of fatal overdoses in Maryland. Next slide. So in our project, the specific goals are to increase access to naloxone. And the difference between naloxone and Narcan, if you're not aware, is Narcan is the brand name of naloxone that is delivered by nose. It's the easiest way to deliver it. But naloxone is also available as an injection. So naloxone is basically the generic name, and Narcan is the brand for the nasal spray. So to increase access and then document the barriers. Next slide. Some of the specific objectives to help us meet those goals are developing outreach materials, figuring out who the heck, where are these construction employers? And we actually have a wonderful data file that tells us who the construction employers are all across the state. And we've been able to categorize them by small, medium, and large. We know that large employers are more likely to have resources like EAPs, you know, like safety managers. But in the construction industry, a lot of the employers are small and medium businesses that may not have the same degree of resources. And so we want to pay particular attention to reaching the small and medium employers that may not have as many resources. And then we're also already, you know, we've identified and already connected with many construction trade union locals and their leaders, and already have training set up through them. Next slide. You know, develop the plan. The numeric goals are to try to connect with at least 1,500 industry leaders, and then of them get at least 125 yeses to talking about the project. Next slide. And then from that to have at least 50 kind of workplace trainings going on, not 50 people, but 50 workplace trainings going on. And when I say workplace, you know, one of the things that we're learning is that we have a nice opportunity to provide training through trade union apprentice trainings. So, you know, that's not a workplace, but it's a way that we can get a lot of construction workers at once. The other thing that we're planning to do with this project is to try to develop some champions among construction leaders so that we can help kind of disseminate the need for this and try to build excitement and get, hopefully get people kind of banging down the doors of the Center for Harm Reduction saying, we want this, we need this. And to have more construction leaders engaging with our toolkit. And, naloxone is a first step. And, we're hoping that through this engagement and talking about this challenging issue, this wicked problem, that we'll get more construction industry leaders adopting more parts of the toolkit, including stigma reducing education and more recovery friendly policies. Next slide. We're trying to learn more about, of those that say yes, what do they have in common? And those that are saying no, what can we learn about them that will help us maybe get them to yes? Next slide. And also just to try to learn more about what the industry is doing related to substance use disorder and opioid use disorder by using the survey that we already have been using in our projects, which asks questions about what's going on with training, what's going on with your policies, what's going on with your benefits, et cetera. And do you have peer support? Next slide. And this is a QR code or a link, and you'll get the slides as well. So you can grab this right now, or actually grab it right now. This will take you to a very short form that will connect you to us. It'll ask for your contact information. If you already know, if you're already among the convinced, like, yes, we want this training and we want naloxone for our people, or yes, we want to work with you. You can answer yes. If you just want to be on our list for more information, this will allow you to do that. You don't have to be ready, but this will get you connected with us. And so I hope you will do that. And it looks.
So I'm gonna leave that up, Dr. Cloran, and it looks like we have a couple comments in the chat.
Yeah, I see that.
So maybe while that link is up, because it looks like maybe a few people are ready to sign up, which is great. So there's a comment here. Are there people who can come to companies to train HR or managers on how to best support our employees with opioid use disorder?
Well, I can answer that. The Maryland Department of Labor's project, where they are piloting the Recovery Friendly Workplace Initiative, is doing that. They have peer specialists that are going to be available to help employers. And so in our follow-up, we can get you more information about those specific locations so that if you're in those, you'll be able to take advantage of that. I'd say if you're not in those areas, then I'd say not yet, but with our toolkit, we are working with the Maryland Department of Health and the Department of Labor to figure out how to make that kind of technical resource available to companies that are interested in this.
And I'll forward the slide for our contact information, that we'd be happy to hear from you and connect you with folks that are part of our advisory board. Some folks are doing some of this work and related work, and we think that naloxone is a real door opener as well. A few folks have signed up to do the training, and they're interested in how do we also look at risks and reducing risks in our workplace from a broader sense. So would be happy to talk with any of you interested in this topic, as well, to get feedback and examples and stories of what you're doing, what's working, and where are some of those barriers. We want to be able to hear from you as employers and employees throughout the state to help us guide our work. Both of us are very community engaged researchers. We're trained as practitioners, and we want to make sure that what we're researching and what we're putting into the toolkit is most reflective of the needs for employers and employees out there.
Wow.
It looks like,
go ahead.
Oh, I was just looking at some of the other chats. So I'm so glad that folks who are new to construction came today, who maybe weren't aware of some of the topics. And then also thinking again, a comment in here about construction events happen all the time and they don't have good options for sober people. I think that that's so important for us to take a step back and really look at the type of events and activities we're engaging in and how that feels, whether is that inclusive or is that exclusive, particularly for folks in recovery. We can certainly have a great time without alcohol. So really thinking about strategies that support recovery are important for us to do.
Thank you so much. We always love working with you both. So thank you, thank you, thank you. And for you all, if you feel enlightened by this conversation and want to learn more, please join us at our industry symposium on February 28th, entitled Image of the Industry. Dr. Cloran and Dr. Fry will be presenting even more information on mental health and opioid misuse disorder in the workplace, with a special emphasis on that construction employer connection. At the same event, we're going to discuss telling stories and showing impact through marketing, high ROI and retention through youth apprenticeship, sponsorship versus mentorship, women in construction, and so much more. So it's going to be a really expansive event. We would love, love, love to see you there. Please register at mccei.org. Check it all out. Early bird tickets are currently available. And that is all we have for you all today. Thank you again so much, Dr. Clarn and Dr. Fry, and we'll see you on February 28th.
Thank you for inviting us, and thank you for being such an engaged, important partner in this work.
Thank you.